We have been very interested in prescribing for a long time, partly because we know it's something that junior doctors are very anxious about when they graduate from medical school and become proper doctors. We also know that prescribing errors are very common, and so we were keen to work with junior doctors to understand their prescribing experiences and see what we could do to help.
We started the project actually on Rakesh, who is a nephrologist up in the north of England. He originally ran the Epiphany project. And they did quite a complex intervention involving several different arms. So they did quite some thorough teaching. They ran the video feedback that is what we then developed this into. And talking to him, he was very keen to spread the project, but the reality is the resource level that we had was much lower than he had. So discussing it with him, his thinking was that the video feedback was the most important section. So we then decided to run a study in Exeter using videoing the junior doctors taking the drug history, but then also writing out the drugs on the drug chart, and then experimented really in how well this would work. So we took the original project and then we took what we thought was the most efficient bit and then applied that in practice.
We had done quite a lot of research to try and understand the challenges that junior doctors faced with prescribing. And having developed a really good understanding of the challenges, we felt really quite well placed to intervene in some way and try and work with junior doctors to see if we could actually improve the situation.
Well, I think in conjunction with Karen Mattick, we were both quite interested in why and how junior doctors make mistakes when they fill out the prescription chart. We know that there is a very high rate of error on the drug charts, running at about 1 in 5 prescriptions written have some kind of error. Now, most of those are relatively minor, we have very minor impact on the patient, but some are actually more serious. And there are certain instances within all hospitals where patients are significantly harmed by the inaccurate prescription. So we were very interested whether using the video feedback would decrease that level of error.
I'd been working with some of the pharmacists and doctors at various grades in the Royal Devon Exeter Hospital, and so we've been working together for a while, both on the previous research. So it was really quite a collective, sort of co-designed approach between that group of people, but in terms of wider buy-in, of course, we had to persuade people to participate in the research. So in terms, if you imagine some very busy junior doctors having to protect time in their days to be involved.
The key stakeholders initially were the core team, which was Professor Mattick, myself, and one of the pharmacists, Hazel Parker. So we had to decide really amongst ourselves that this was a project that we thought was worth running, but really the honest truth is we needed to find funding to pay for the pharmacists' time to run this project, and the funding we got paid for about 2/3 of that pharmacist's time for a year. So we got matched funding, so we got the Regional Health Authority, the Academic Health Science Network, to fund half of it, and we got Pfizer, a drug company, to fund the other half. Pfizer were interested in this because they'd funded the original project, and then they were interested about whether this could be spread from the initial enthusiasm of one project in one hospital more widely. So the key thing really was the funding. The pharmacy department in the hospital were very engaged with this from the very beginning, so it didn't take much persuading for them, and I am a consultant surgeon, so I was able to authorise it easily to be done within our clinical practice.
It was the clinicians who were involved in recruiting the patients, so predominantly one of the pharmacists, and the patients that we were working with were generally those waiting for surgery on the surgical wards, and I understand they seemed very happy to be involved because it was something to do while they were waiting.
I think we were very much driven by the enthusiasm of Hazel, our lead antibiotic pharmacist, and then the co-learning and the opportunity to do research with the university, and that combined with the fact that there's very little hard evidence of the benefits pharmacists directly bring to patient care. At least it's not published in the literature, and we were keen, I think, to be part of generating some primary evidence to show what difference pharmacists can make to patient care and patient safety.
So the intervention was a really simple intervention where we videoed junior doctors taking drug histories from patients, and then we also videoed separately them writing up the drug chart, because generally the prescribing actually happens in a different place to where they take the drug history.
We're very lucky to have a very skilled and enthusiastic lead from the university, and lots of enthusiasm within the group of pharmacists that were working on the project. I think we had the benefit, I think, of our getting funding, and funding made the difference, so we could employ a pharmacist who was just doing the project for half of his clinical time. He was also the person who stepped forward to do the project, was part of the surgical assessment unit, so knew the patient group, knew the clinical area, and was well integrated in the multidisciplinary team. So once we had those people on board, I think it just went.
Well, I was primarily involved in the design of the intervention. We looked at what had been done in Leicester, and then we thought about how we could adapt it for use locally. I was very keen that we would involve pharmacists in the intervention. Obviously, being a pharmacist, I think it speaks to our expertise. And I also think we're well placed within the team, sitting outside the medical hierarchy.
The process for the intervention was basically we gave a doctor a drug history pro forma and a drug chart, and told them, go take a medication history from the patient and write up a drug chart. While they're doing that, we put a GoPro camera on the table next to the patient, pointing at the doctor, and then invariably they moved to actually write up the drug chart instead of being sat in front of a patient and having lots of awkward silences. So we got them to pick up the camera and move it with them to wherever they moved to. And then we filmed that bit of the prescribing process as well. So after we filmed them taking their history and writing up the drug chart, I'd go and watch the footage back myself, make note of anything that was a bit odd or really good, and then they would come and we'd arrange a time later on to go and watch the footage through, and we'd talk about what went well, not so well, what could have been better, and any sort of action plan for them to improve their prescribing.
I decided to take part in the project because I'd heard other colleagues that had taken part already, and they said that it was a really useful exercise. As a junior doctor, we don't actually get that much feedback, particularly one-to-one from pharmacists or from consultants or anybody else in the team on prescribing, so I thought it was a useful opportunity.
The experience of taking part in the intervention was very interesting, enjoyable, easy, didn't take very long, and it was quite a fascinating insight into the situation of what prescribing looks like, what it looks like when you're writing a drug chart on the ward.
I think the thing that I learnt the most was I was amazed at how often I was interrupted whilst I was writing the drug chart. I think I was interrupted something like 12 times.
I think the main thing I learned from the intervention was just how often you get interrupted when you're trying to write a drug chart on the ward. It was kind of eye-opening to see just how frequently that happens.
When we prescribe on the ward, it's a very busy environment, and I actually found that taking the history itself wasn't such an issue, but it was then when you were writing up the drug chart that's when you were interrupted multiple times during prescriptions. It's where errors occur, and I hadn't realised just what an issue that is.
So yeah, when we started doing this, I had no idea what sort of reduction in errors we'd get, but we did actually get it was 39% reduction in prescribing errors, which is not insignificant.
It was. I came back from mat leave and I was really pleased with the results. I think they're amazing. I didn't think that we'd achieve something that was statistically significantly better. You know, I thought it would be really good for quality and for patient safety, but I didn't think we'd get statistically significant results.
But one of the biggest things they learned was how obviously distracted they were when they were writing the drugs on the drug chart afterwards. And they had not realised this, and it was only by being videoed when they do it that they actually realised the distractions that were going on. And there was one instance, it was almost as if we'd set this up, but we hadn't. One of the junior doctors was filling out the drug chart, sitting at the nurses' station, whilst the maintenance people came in to redo a socket on the wall, and that socket was right in front of where the junior doctor was writing up the drug chart. So we have the video of the maintenance people coming in while the junior doctor is writing the drug chart, and they're unscrewing and tinkering with this power socket 20 centimetres away from the junior doctors, filling it out. And so the juniors realise the impact of external events when they're writing up the drug chart. Well, I mean, there are two bits that really excite me about this project. I mean, the most dramatic thing was the reduction in errors that the junior doctors make. So in a brutal, in a sense, that's by far the most important thing, because we were looking at improving the safety of care that we give to our patients. We know that errors in terms of medication are one of the most common mistakes we make. So having a project that halved the rate of errors in terms of prescription to the patient is fantastic in terms of how this can provide safer and more effective care to our patients. So that, on one hand, that was, I mean that is for me the most exciting bit. But the other very interesting bit is how the junior doctors valued this kind of feedback, because not only was it improving the care the patients got, but it certainly was a developmental tool for them, both in related to how they take the drug history, but also developing them as individuals and professionals.
I have changed my practice as far as working on a busy ward allows. When I'm writing up a drug chart, I either try to find a quiet place, or if nursing, quite often they see a doctor on the ward and they kind of grab you and say, can I just have a fluid prescription? Can I just let you know this? And when that does happen, I try to say, can you just give me 5 minutes? I'm going to write this drug chart, I'll stay on the ward and then come back to me, which is something I hadn't really done before.
One of the nice things about this project is just how simple it is. All you really need is a pharmacist with a bit of time and the GoPro camera, which you can obtain very easily. It's the sort of thing that pharmacists already look over drug prescriptions. It doesn't take a lot of extra effort to film an F1 doing it and give them feedback on it. And as I think people have said, the time you spend on performing an intervention like this, you probably make up later with reduced drug errors. So easy to roll out.
The easiest way to try and spread this is to just do it, which sounds very rich for me to say, but you just find one person who's willing to be filmed and one pharmacist who's willing to give a bit of feedback, and something good will come of it. It won't be time wasted. It doesn't take a lot of time to do any of these iterations. At very most, it takes a pharmacist 4 hours. About 4 hours of pharmacist time and about an hour of junior doctor time. And that's at the very most. But it's absolutely worthwhile, and it will save you time further down the line.
I think for me, I think it works really well doing it in a real environment. I think it's easier, so it's more likely to make it sustainable.
Top tip one is convince the pharmacy department to release the funding. And the other really important aspect is engaging a pharmacist who is very proactive about running this project. During this project, we were lucky enough to have Odran, who was incredibly enthusiastic about running this project, and the key will be identifying that person in different hospitals to run the project.
I think for me as an individual, it was really interesting to work alongside university professionals, research academics. I think as pharmacists we don't always get a chance to do that, and that was an inspirational part of it. I think also seeing research taking place in a real hospital environment was really great to see. And we really hope that we'll be able to generate more interest in the project going forward and embed it in our clinical practice.
I think it was very exciting to actually be able to make a difference, because as academics we work in the university, and to feel that our research was making a real difference to patients was absolutely fantastic. And although we had hoped, because we designed the project with junior doctors, we hoped that we would meet their needs. We weren't sure whether or not we'd actually be able to demonstrate a difference in prescribing errors. So we were really pleased and encouraged that our really quite simple intervention that we designed was able to make quite a tangible difference for patients.
I think that it's just great to have an opportunity for a clinical pharmacist and clinical pharmacy teams to be involved in generating evidence of the benefit of pharmacists bring to patient care.
I think working well with your ward pharmacist is quite important. I think if you've got a good relationship with your ward pharmacist, I think it's much easier for them to point out things that you're doing wrong. And so when you're moving around, a ward pharmacist coming up and almost booking that in with you kind of creates that relationship, and actually it might not necessarily be that intervention that helps you improve, but having that relationship with the pharmacist I think will help you improve even further going forward.
I thought it's a fantastic project, it's a really good idea, and I would strongly encourage people to take part, because I think it brings to light areas of your work for other things as well that you probably wouldn't realise.
Thank you for the Epiphany project. It was a really valuable experience and I greatly enjoyed it.
Very worthwhile, very positive.
The key message for us as a team is we've demonstrated this works in a single environment in one hospital. What we're working on now is working how you could spread it across the whole hospital, but particularly how you can take this to different hospitals and get it applied consistently and continuously.
One of my reflections on the project has been what a pleasure it's been working with different groups of professionals. So seeing what the pharmacists have to offer the doctors, particularly junior stage doctors, in terms of their professional development, and thinking about how support might come from a range of different professionals rather than those who are in the same profession. So I think that's been very interesting to see and very positive.